what is the data that we're measuring to improve our healthcare system today? It's volume. It's just we have a health services system. We don't have a healthcare system. We're measuring the volume of services. We're not measuring, are people doing better?
Hey, I'm Costas.
Hi, I'm Lester, and welcome to another episode of What's If RWE. And how was your summer so far, Costas? I know we haven't chatted too much since the summer. So how's things going with you?
Summer's going terrific. Had a lot of time with the family. Did tours of New York this year, so we checked off the list pretty quickly. But back in the office and raring to go to start September. Mostly raring to get the kids out of the house and back into school, but work is great too.
Yeah,
absolutely.
Me, just Vancouver is one of the only times in the year where Vancouver is beautiful is the summertime. So I just stick around Vancouver. This is like the one time where we don't really have to go out because the rest of the year it's rainy or snowing, right? So those are times where I try to maybe make a little bit of trip of it. But on tangential notes, sorry we took that little tangent here. Of course, we have another very special guest with us today, someone who is what I would call probably the guru of value-based healthcare, and we'll learn a lot about value-based healthcare today on the episode. Eva Villalba, and she is currently the executive director of Quebec Cancer Coalition, or I'm a butcher in French, but I'll do my best, is Coalition Priorité Cancer au Québec. How are you doing?
And welcome. Really good. Thank you, Lester and Costas. Happy to be here.
Excellent. And of course, it looks like a beautiful day in Montreal right now.
Yes, after like 4 days of torrential rains, which make it very green and lush, we finally have nice weather to finish the summer off and the summer vacations.
Perfect. And thank you very much, of course, for jumping on the podcast, because you're definitely the guru of what I was saying in the beginning of this podcast of value-based healthcare in Canada. So maybe you can start things off there. Like, what is value-based healthcare, and how did you get into it? Like, why should people care about value-based healthcare?
Yeah, it's really a passion of mine, so I'm really happy to be here and talk about it. So I've been working in patient advocacy, mostly in oncology, since about 2008. And I started off working in palliative home care at a time when in Quebec, we were actually working on the Dying with Dignity Act, which led to medically assisted dying or MAID. In Quebec and across Canada, of course. And what I saw there was really the power of patient advocacy, how patient advocacy organizations could really influence public policy and the amazing change that we can do. But also, it really brought me close to patients. I was also volunteering at the same time with people with palliative care, and I really got to see the impact that it made when you listen to patients. My background is I did my bachelor's in psychology and behavioral science at McGill, and applied linguistics. So the value of language is also really important to me. And then while I was working in palliative care, I did an MBA in French at HEC Montréal, my third language. And I really wanted to apply best business practices to the public and nonprofit sector. And I started getting involved with this, the Coalition Priorité Cancer au Québec, as a board member. And so I really saw how we were, again, able to really influence public policy and lift up the voices of people affected by cancer. So I've been doing that for a while. And I saw that there were really issues with the fact that science and medicine was advancing at such a rapid pace, but that our government policies, our reimbursement and access policies were definitely not going at the same pace. And I was seeing all of these amazing innovations in terms of precision medicine in particular, and how inadequate our reimbursement and access systems were, because the model is based on this like super old way of doing things, and even old like medicine, right? Old, like they're 20, 30 years behind. And so I realized that we needed a shift in the paradigm. We needed to think differently. And our current system is really, it really prioritizes cheaper drugs. It prioritizes, let's try the same thing on everyone and hope that some people make it through. And whoever makes it through can then have access to the newer thing. And then whoever makes it through that second step, maybe the third. Why should we wait 1, 2, 3, 4, 5, 6 lines of treatment to get the right treatment? Okay, why? Because our current system is meant to just make everyone go through the little, production line of everyone in a row, and whoever makes it to the end, maybe if you're lucky, you're going to get the right treatment at the right time for the right patient. Our current system is not made to prioritize that. So why value-based healthcare? The first thing that really lit me up and made me realize, okay, we need something different, is that realization with CAR T therapies that were coming on. They were coming down, and Quebec, as you know, was a pioneer in giving access to CAR T therapy in Canada. And I saw that our system was not meant to encourage that type of access to innovation. And because it's very expensive, yes, but what are we getting for our money? And so, really, to simplify it, to vulgarize it, value based healthcare is prioritizing value defined as an actual improvement in the health outcomes of patients. So, value from the perspective of patients relative to the cost, but not at one point in time like we're currently doing now, but the cost over the whole trajectory of care. So you're going to prioritize treatments that avoid hospitalizations, that avoid complications, that improve health outcomes. And that's not what we're doing. What we're doing is we're prioritizing the cheap thing, the old drug that's on a generic or biosimilar now. Like, but does it work? Are people doing better? Does it work for everyone? No. And so value-based healthcare really says, let's actually base our decisions on not how much it costs, but what we're getting for our money. And what we're getting for our money in a more holistic sense. In a holistic sense, when we're talking about like, how does it impact patients? How does it impact families, communities? How does it impact the system? In Canada, what's more important than how much it costs is how do we better utilize our very, very extremely limited resources? How are we more equitable? And so I had that realization in 2019, and I did an executive ed program at the University of Texas, Austin, with the co-founder of the value-based healthcare movement, Elizabeth Teisberg. So Elizabeth Teisberg and Michael Porter wrote a book, Redefining Healthcare, in 2006, that really changed everything and that outlined value-based healthcare. But Michael Porter gets all the credit. He's very famous in business strategy. Anybody who has done an M.B.A. has read his articles and his work. But it really started, and this resonated with me, it really started because Elizabeth Teisberg had 3 children that were sick children, and they needed to navigate the health system. And she's a systems engineer. She was also a Harvard professor in systems engineering. And she's like, there has to be a better system. We got to do this better. She got together with Michael Porter and they wrote this book. And so that resonated with me. I was like, I'm defending patients, but our system is not made to help them. It's made to, what do we measure today, right? And it all gets down to measuring, improving what we measure. And that's why I think that Exactis is, really well placed to understand the value of value-based healthcare, because you need data to make better decisions. You need data in real time. And what is the data that we're measuring to improve our healthcare system today? It's volume. It's just, we have a health services system. We don't have a healthcare system. We're measuring the volume of services. We're not measuring, are people doing better? And so that's the radical paradigm shift,
Yeah, Eva, I was just going to ask, what is the metric today? Because you're absolutely right. There is no one that is assessing, are people doing better? That's not, and I think it may shock people. I'm sure when you speak to people, you probably get these blank stares back, like no, that's not possible. I mean, they're trying to take care. Yeah, they're trying to take care of us. They care about if we are doing better. But health is not the goal of the system at this point. It's a byproduct.
Exactly. And what we're measuring are activities and volume. And, we like to say that we're measuring access, but we're not. We're not measuring access. Oh, if everybody gets a mammography, are we doing our job? Not really. Do we want colonoscopies for everyone? No, we do not. We want colonoscopies for the people that need colonoscopies, you know? And so in 2020, in full pandemic, I was the first Canadian to do my master's in value-based healthcare. It was interesting during the pandemic, but it was also very rich. And that's when we really started to learn like measuring outcomes that matter to patients, measuring outcomes that are real indicators of success for our healthcare systems. How do we actually prioritize, for example, earlier interventions, improving, having a more predict and prevent approach rather than a break and fix model that we have now. And so there's a real paradigm shift, and it starts with, what do we measure? How do we measure it, and why do we measure it? And the ultimate why do we measure it, that ties back to why I'm so passionate about patient advocacy, is don't assume that the doctors who have very good intentions are going to understand all of the metrics that matter to patients. They have their own perspective, which is very important, but it's incomplete. You need to understand what are the outcomes that matter to patients, and then you'll have better adherence, you'll have better outcomes. Sometimes people they want to be able to go back to their activities of daily living. They want, the things that are important for doctors, like the binary yes or no cancer. There are patients in palliative care, for example, that will tell you, I would rather live really well for 3 months than suffer the last year of my life. So what can I do to do that? And sometimes that's a different kind of treatment or a different intervention or no intervention at all. It really depends. But value-based healthcare really turns a paradigm on its head and says, don't assume, just measure, and then use that data to inform better decision-making, better resource utilization. And what's good for patients is good for all stakeholders, but not vice versa. And that's what our current system does.
Yeah. And so I think there's so much to unpack there, because I don't think we really ask patients, what is it that you care about? And I think we've talked in the past with others about, goal attainment and how that can be very different patient to patient. So
Yep.
When you try to assess what's the best value that we can deliver, it also ends up being patient to patient, but that's hard to do at a systems level. But in the US, they've already been applying this. And I don't know that cancer was, I'm fairly certain cancer wasn't the first area. I think they started off in something simple. It was like orthopedics and
hip and knee replacements.
Right?
Yeah.
Yeah. So, are you preventing infections? Are patients able to stay out of the hospital and heal and go on to their, the activities that they want, right? So fairly low-hanging fruit, but how do you see us applying it in Canada? Is it trying to sort of replicate what's been done in the US first, or is there a different path for Canada?
So actually, we're just completing a 2-year project, a value-based healthcare demonstration project in colorectal cancer at the Jewish General Hospital. And we're actually unveiling our final report on October 15th of this year. And what we did is there's the ICHOM, which is International Consortium of Health Outcomes Measurement. They have international standard sets of what are the patient-reported outcomes, or PROMs, patient-reported outcome measures that you should be using for different types of conditions. So there's 4 for cancer, the 4 big ones, right? So lung, prostate, breast, and colorectal. And so before we went in there, we actually took that wheel. There's like a wheel of outcomes that matter to patients and also doctors. And we asked the doctors, and we published this with the Conference Board of Canada, it's on their website, how many of these outcomes are you measuring? And unsurprisingly, the doctors said, all of them. Now, they had good intentions. They assumed that everything was being measured. But in parallel to that, we actually, at the Quebec Cancer Coalition, did an experience group methodology, which is like a type of focus group where you really let patients speak amongst themselves and you understand the outcomes that matter most to them. And unsurprisingly, the things that the outcomes that they cared about, they were found on the outcomes wheel of ICHOM, but they were exactly the things that were not measured in reality. Only 45% of the outcomes that could be measured were being measured in clinic, like at the hospital. But the patients, what they cared about was the other, like, 55% of what should have been measured. And so what's interesting is that through this demonstration project at the Jewish General Hospital, now we're measuring all of it in real time. Patients get a link, they fill it out right before their next visit, but they can also self-initiate. And so let the care team understand how they're doing in terms of their symptoms. If it's a preoccupying symptom, a preoccupying outcome, like, it could be pain, it could be mental health, like anxiety or depression. It could be, like, in the case of colorectal cancer, gastrointestinal issues. It could be constipation, diarrhea. These are very impactful in a negative way for your quality of life, right? And so they will get an info sheet immediately to act on those symptoms and to improve their life. And if it's distressing, they will get a call back from the nurse navigator within 48 to 72 hours. And that has been shown to improve the quality of life of patients, but also to better manage resources. There's less ED visits. There's less time spent even in the consultation and outpatients. And patients feel better. They feel reassured. And so it's a win-win-win for everyone. And that's a really concrete example of how it can be used in oncology, because the problem with hip and knee replacements and all of the easy kind of tests of value-based healthcare is that they're not scalable. Like, if you do hip and knee really well, good for you. It's not going to be scaled to the whole system. We're aiming for nothing less than whole system transformation. And by doing it in something complex like oncology, then it can be scaled. So we're already starting to do that knowledge transfer, include other hospitals in Quebec and in Canada. We're presenting at ICHOM, actually, the ICHOM conference in Amsterdam in October. So Erin Cook from Quality and Karine Lepage, who co-led this project with me at the Jewish, we're presenting at ICHOM. So we're really spreading the good news of, like, look, it can be done in something complex like oncology. This is how it helps people. This is how patients feel about it. This is how healthcare professionals feel about it. They also appreciate this, validation based on data that patients are doing better, So that these are some examples of, yes, it can have an impact. And now next year we're starting in lung cancer at the EUCPQ, which is the Lung Cancer Institute in Quebec City, just to show that we can replicate the model. And then we'll also be collecting PROMs, like I mentioned, but in lung cancer, PREMs, which are patient-reported experience measures, and also impact, like the experience measures of providers. So how do healthcare professionals feel when they adopt this value-based healthcare model? And we know that it's more motivating to them, it's more rewarding. They see an impact of doing it with real-world data to make their decisions on.
Interesting. And I'm sure you're chomping at the bit there, Lester, with questions, but one more maybe from my side. So you talked a little bit about the data, and obviously at Exactis, that's one of the things that we think absolutely needs to be captured in a systematic and high quality way in order to be able to do these analytics, because without good quality data, you don't know how well you're doing. What else in the healthcare system as it sits today, what is the other sort of infrastructure that needs to be built in order to allow value-based care to become the standard? Because I don't see it as something easy that can be implemented today. There's got to be a lot that needs to be built.
Absolutely. And it is very data reliant. So one of the 6 elements of what's called Porter's value agenda, like how do you do value-based healthcare, is building an enabling IT platform. And so in Quebec, we just got finally this new health data law, which is going to help, but it's not really ready. And it involves things like interoperability. One of the things that we realized, even when we asked the doctors, like, how much of this do you measure? the information was fragmented in like 12 different data silos, 12 different databases. How can
We
you
know.
actually consolidate? You know more than most, right? So how do you consolidate all of that information on one single dashboard to get a whole picture view of what's happening? The the results, the health results, which is what we should be measuring, not the volume of services. If you operate on my left knee instead of my right knee where I have my torn meniscus, the doctor still gets paid, but I am now doubly, handicapped, and can't walk. Now I have worse outcomes, right?
Mhm.
And so we need to start tying reimbursement to outcomes. So the first step is measuring outcomes systematically and in a way that we can have this whole picture view of everything that matters, not just what the doctors care about, even though that's important. We want to include that, but then also add measures of quality of life in a systematic fashion. Standardize the collection of these proms as well, and then tie it to costs. So the first step is measure proms systematically, tie it to the CROMs, to the clinical reported outcomes. How do we have this whole picture view? And then also add the things that quality usually measures, which is like process metrics, like delays and, okay, fine, if you really want to measure volume, that's fine, but make sure that it's the right volume. And then how do we tie all that to costs? And so right now, I think across Canada, what's really missing is a real transparency of costs, because we want to make decisions based on not what costs less, but what is more value over time. So sometimes you think, oh, well, this diagnostic test, it's so expensive. We're going to wait till the fourth or fifth line of treatment before we actually use it. Okay, but if you just spent money and resources and the person's life on 1, 2, 3, 4, 5 lines of treatment that don't work, was it really a better use of your money and your resources? Or did you flush it down the toilet when you could have just spent more money on this test, but then avoided 3 lines of treatment that didn't work, right? And so I think we need to tie the cost to the outcomes. First, measure outcomes in a standardized way. And I think that's what Exactus can really contribute to. Good, standardized, quality data for decision making. And then how do we tie that to a much better understanding of how much things cost? So in Quebec, we have a sort of new-ish system called CPSS, or coût par parcours de soins, cost per trajectory of care. And so we're starting to understand at least episodic kind of bundles of payments, or bundles of how much things cost. We know how much radiotherapy costs in oncology. We know how much organ transplants cost. We know how much, definitely hip and knee, we know how much that costs, that because we've been doing that for a long time. So how do we actually understand the cost over the whole trajectory of care and then tie it to outcomes to understand, for example, in our project in colorectal, we saw that there was an opportunity to do prehab or prehabilitation, like doing therapy before your surgery will actually make sure that you get out of the hospital faster, you have less pain, you have more mobility, you're going to do better. You're going to have better outcomes. But usually the regular thing that we do is we make people do surgery, and then when they're struggling, then we tell them to go see a physiotherapist. Is it cheaper? It's what costs the most in our system is we don't have enough beds. Okay. So let's make better use of our beds, of our limited doctors and nurses, and let's maybe use other healthcare professionals more in advance of the trajectory so that we can improve outcomes. And ultimately, when you look at the real cost, it's going to cost us less. And it's the same. That's really why I got into value-based healthcare, because I knew that patients needed access to precision medicine, but our system discouraged access to precision medicine because it's always going to look expensive, even though it's higher value. And so we really need to change what we measure and why we measure it, and focus on the ultimate objective for any, especially public healthcare system, should be creating health, not just providing health services. And we do that by value-based healthcare.
Great. Actually, I learned a lot there, but there's so many, again, threads to pull on here. But one thing maybe I'll tie into a previous conversation we just had with someone that's more in the policy space. He actually helps the federal government. That episode's with Tyler, and he kind of very, very generously gave us his time to kind of educate us on how the federal budget actually gets put together, right? And that's like something that was incredibly interesting to us. It was he brought up something that I didn't fully, I guess it makes sense, but it wasn't completely obvious. He's like, the federal budget, it's like the goal of it is not necessary to improve like health care outcomes. That is not the goal of the budget. The budget is like how much things cost, and then what do you get for the cost, right? And here's a list of a whole bunch of things that people want. Okay, what can we fit in that like equates the overall makes the numbers go to zero basically, right? So there's not doesn't cost more than it actually generates from a revenue perspective from taxes, right? And that was very kind of interesting, very, very telling. And I'll tie it back into kind of like value-based care component is value-based care, let's say in the cancer context, overall in the long term will reduce costs from a total cost perspective. That's the goal, right? But requires some initial investment into it, right? So how do we convince policymakers to make that initial investment seems to be the one of the challenges. So I don't know if your group has actually started doing anything there, because on a side note, just so this is what he told us is not like it's not that we know this for a fact, but it seems like from a ethos perspective, he was letting us know that a cancer is no longer kind of the big issue that politicians care about. It's more mental health is actually the big issue after COVID. So in some ways, he says like the vast majority of like they say the policy perspective, they think, oh, we actually solved this whole cancer thing already, because you see the cancer rates are going down, or actually the mortality rates from cancer have been going down, improving. So that is not a problem. We solved that problem already. So why do we don't need to put dollars into that? We need to put dollars into this this mental health issue, which is of course an issue, right? But just wanted to, what's your perspective on that? I was really kind of surprised when you kind of mentioned that to us.
So first of all, I think that we've been a bit cognitively lazy in the sense that what is easy to measure? Volume of activity. So when you say they have to rationalize the budgets, they're like, this is how much money we're getting, this is how many services we're giving, or to how many people, yay us. Okay, it's like intellectually lazy in the sense that what we should be measuring is, are people doing better? Are we saving lives? Are people going back to work? The government should care about that, because then we get to pay taxes and like fund the healthcare system. But historically, it's been very difficult to measure health outcomes because they're not standardized, because our data infrastructure, as you know, is super fragmented, poor quality, not interoperable. But now with AI, with all kinds of middleware, we have all the technology that helps us take disparate health informatics systems and kind of aggregate them and centralize that data to have this whole picture view. We're able to do things now with data that we weren't able to do before, right? So, and I think the recognition of the importance of data standardization, so that's helping us. That was something that we needed. So I think we'll be able to use that data to make better budget arguments. And I think that what we need to be doing is not how many, changing the metric. And so really saying, okay, well, we can measure the health of people. The other argument that we're working on is demonstrating that a stage 1 or 2 or even 3 colorectal cancer, as an example, costs the system so much less than a stage 4 colorectal cancer that requires access to really, really expensive precision drugs, for example, or in hematological cancers, like, okay, we know that CAR-T is super expensive. Let's just keep that for those that we can't avoid. But what can we do to detect it earlier, to help people be diagnosed earlier and screened? And because it costs the system less and it's best for citizens. As a patient advocate, I wish that the government would just care enough about patients and citizens to do the right thing. But we have to say that, and it will save you money that you can reinvest into helping even more citizens, even more people. And so we need to have the economic argument as well as the ethical, compassionate, patient advocacy angle of it's just the right thing to do for people. You want to keep people in their communities, close to their communities, working, being with their families. That's what people care about. From coast to coast, it's the same everywhere. That's what people want. Do they want more healthcare? No. Nobody wants, and this is the paradigm shift. Nobody wants an all-you-can-eat buffet of healthcare services. And yet that's what we measure. And the assumption is if we let people tell us what they want, everybody will want everything. No. Who wants a colonoscopy if they don't need one? I mean, maybe there's a few people, but very rare, I assume. So really what we want is to give people health and not health services. And the best way is to ask them, because sometimes they don't want that extra treatment if it's going to mean a degradation of their quality of life. Give them the information that they need to make informed decisions about their care. So now we're talking about shared decision making, which is also enabled by really good real-time data, right? So how can we use real-world data to help patients inform their decisions? I just, earlier this year, I was in Amsterdam. I go every year for Value-Based Center Europe, where I'm the Canadian ambassador for them, and I go regularly to their VBHC prize. And I will give a little shout out to the West Central Montreal Health Network that actually won the International Value-Based Healthcare Prize for their hospital at home model, which is very value-based. They collect data, they improve outcomes, they lower costs, and they better use resources. And it was the first time a Canadian won. And so Aaron Cook and Ala Ali were there to get the prize on behalf of the Sears Centre West of the island of Montreal. And so I really believe that things are changing, but we just need to be measuring the right things, showing that it could be done, and then using data to show how it can improve. And in Holland, what they're doing is, because they've been collecting prompts for so long with real world data, they then can share with a patient. Let's say Costas, okay, you're a 40-year-old male, you have early stage prostate cancer. This is what other men like you have had when they tried treatment A bit more nausea. Treatment B, fatigue. Treatment C, they were wiped out. They couldn't work for 3 months, but then they came back in force. What makes more sense for you as a CEO, as a father, as somebody who works remotely? You might be able to make different choices, And so using that real world data to make better decisions, better treatment decisions for you as an individual, for your family, that's something that we aspire to, but it's already being done in countries like the Netherlands. And so we have a model, but the first thing we need to do is prioritize this collection of real world data. And then also recognizing that we need to empower shared decision making for patients, and that they're not going to want an all you can eat buffet. They're not going to want all the things, but we just need to give them the information so that they can choose the best things for them in their context, for their family, for their lives. And ultimately, they will choose more conservative choices than what the healthcare system and the government has assumed that they would, right? Yeah. And that will make a better use of our limited resources too.
It's interesting because I don't know if you know this about me, but my roots are in health economics. So I'm kind of a reformed health economist these days, because one of the things that you touched on right there is that there is, when we do models and try to understand what is the cost going to look like for the introduction of a new treatment, you go do quality of life tests, you look at patient preferences, but you do it at a population level. And, in the old days, we would have, a point estimate, the quality of life for this patient or the utility for this patient is going to be this. And that's what we apply to the amount of time that is gained, in terms of life years. Mm-hmm. And then, over time, we got more sophisticated. So now we can actually add in a distribution. So you can sample from the distribution. So the math of it gets better and better. But I think what people forgot is that populations are not just a distribution. Each of those individuals have a different preference, and the outcome or the value to them is very individual. And that's the piece that we have not been able to replicate from a modeling perspective.
Yeah. And I would tie it back to equity, right? So this population model has certain assumptions, and there are always going to be some populations that are left out of this assumption.
Yeah.
And we will continue to dig the inequity gap for those people. And so value-based healthcare, because you're actually measuring the outcomes of each and every person to optimize the trajectory for them based on standardized practices. So the tools are standardized, but the responses and the preferences are personalized. So it's more of the Pareto principle, like 80-20. So like 80% same for everyone, but the 20% is really how you tweak the model to give people just what they need and not what everybody gets, you know? And so that makes for a better use of resources, but it also is much more equitable because people won't fall through the cracks. And the other thing is that you can actually sub-segment and understand that, like, certain vulnerable populations always have poorer outcomes. So I was just in Ontario, and I was talking to some managers of health systems there, and they were finally looking at some data and realizing that most of their ED visits came from like 2 postal codes. And those postal codes had twice as many hospital emergency room visits than the rest of the catchment area. So obviously there's something to be done. So once you have the data, you can actually zero in and say, okay, why are they having these outcomes? Why are they using more resources? What is different about them? How can we actually adapt our model? How can we be, you know, maybe some more preventative measures, maybe working in collaboration with primary care? You know, what can we do to lower that utilization of these frequent flyers? You know, what is common to them? And so we need the data to do that. And so I think that the economic models and, you know, the pharmacoeconomic models, they like theoretically used quality of life, but to be honest, and no offense, I feel that there's a little bit of like humanity missing in these models, you know, like you just assume that you like understand the quality of life, and you're not talking to the people like I am, you know. I'm talking to families all over Quebec, all over Canada. I know what they're going through, and they don't feel that their quality of life is really being captured by these pharmacoeconomic models, you know. And so you know the thing they say about assuming, right? Like you shouldn't assume. I'm gonna be nice. Everyone knows what assuming does, right? It makes an ass out of you and me. So we the best way to be equitable is to actually ask everyone to not make assumptions, but let the data speaks for itself. And that's where I think your platform can really make a big difference by standardizing good quality data that we can use to make better decisions for health systems, for healthcare professionals, but also for patients. And then allowing them to use that data to make better decisions on what treatment, in what order, what healthcare professionals, where to give the treatment. You know, we have a very hospital-centric kind of view of our healthcare system. That is not the most efficient or the best cost utilization. How can we actually decentralize some of these things? Does everything absolutely need to be in a hospital? I think COVID really showed us that the errors or the dangers of doing everything in the hospital. And the more we do things in the community, that's what patients want. They don't want to miss work. They don't want to be away from their families. What can we actually, decentralize and have in the communities, and then keep all the specialized stuff for the hospitals? And then, of course, there's all the remote monitoring, the virtual care that we can throw in there. That has been shown to improve outcomes as well. That's why the hospital at home model of the Jewish General Hospital and the West Central Health Network was really interesting, because they were able to provide better outcomes for less costs, less resource utilization. And it was a win-win for everyone. And that's really value-based care. You're improving outcomes, you're lowering costs and resources. That's value. That's value for a system. Now, how can we scale it up? But it requires data, really good data infrastructure. And I think that's what we still need to work on a little, is like, how can we actually make quality data an absolute priority? How can we use that quality data? It's not just the collecting, because just measuring is not enough. Some people, they measure problems and they congratulate themselves and they think that poof, we're doing value-based healthcare. I'm sorry, honey, you're not. You need to be able to use that data tie it to a better understanding of resource utilization and costs,
Mm-hmm.
or at least use that data to make better decisions on treatments. And that's not what we're doing yet, but I think that's where we're heading. And there's more and more people like getting trained on value-based healthcare. I'm doing a couple of trainings now in different hospital systems and across Canada. And my vision is to like build capacity, build this wave of people that don't just use value as a buzzword, but actually understand what it means and are committed to delivering this win-win-win solution for the whole system, and ultimately primarily for patients, for citizens, for families.
Actually, I learned a lot from just actually something clicked for me when you're just having this conversation. Is for some reason I always thought, oh, value-based healthcare, that means like we're injecting some novelty into the system, and that's dangerous, right? Like in some way you can think of it that way, right? But what you're talking about actually is you're not suggesting that we should implement some sort of device or drug that's not clinically effective. You're just saying this thing is clinically effective. Right now, we don't use it because the costs are too high using this model. But
Yeah.
change the model because actually all these other costs are actually should be included as well, right?
Exactly.
That offset the actual initial cost, right?
Exactly. And thank you for highlighting that, because I think people are like, oh, not another kind of, radically different, trendy kind of way of doing things. No, it's actually it's a paradigm shift in the sense that it's a mindset shift. We're changing what we prioritize and what we value, and that should be not thinking of how much does it cost, but what are we getting for the investment, and that the ultimate goal of a healthcare system should be health and not health services. So that means we need to measure it. So really, we're not asking people to radically change the way that they work. We're asking them to measure it and to actually do that continuous improvement based on real world data. But there's a second element, which is, so like I said, too often people think that they're measuring proms and poof, they're doing value-based healthcare. You really need to tie the health outcomes to the costs, and then you can include other metrics too, like quality metrics, like delays and things like that, and clinical outcomes, of course. But what's also missing is just doing that in itself, again, is not going far enough. You also need to better integrate care, data, and funding. So the integration, if you don't have data, you can't do it. So that's, you start by integrating data. That means the data has to follow the patient, whether they're at the hospital, the clinic, the pharmacy. The data has to follow the patient. The second thing is integrate care. The healthcare professionals today are not working in an integrated fashion. There's a model in value-based healthcare called the integrated practice unit. So today what we have is, we call them interdisciplinary teams, multidisciplinary teams, but are they a team, or are they individuals intervening sequentially along the trajectory of care? Everyone's looking at a piece of the elephant and nobody sees the whole elephant. Some think that the leg is a tree. Some think that the trunk is a rope. Some people think that the body is a wall. Okay, but nobody sees the whole patient, right? So a real integrated practice unit, a real team that is integrated, will see all of the elephant all of the time and make decisions based on not just the surgical outcomes for a surgeon, but the mental health outcomes, the pain outcomes, the mobility outcomes, the return to work outcomes, and everyone is mutually accountable for all of the health outcomes of the patient, because the ultimate goal is more than the binary, you live or you die, you have cancer or you don't. It's much more than that. And we all care about more than just yes or no cancer. If I live, but I have a terrible quality of life and I'm suffering, is that a win for the system? It shouldn't be, right? And so that's why the integration of care is important. And then the third element is that integration of funding and payment. And so Quebec is heading in that direction, whether patient-based financing or FAP, financement axé sur le patient. So they're looking at a small scale now, which is better than doing it all at once. Because if you do it all at once, everyone gets discouraged and nothing happens. So they're doing little bundles, and they're understanding, okay, radiotherapy costs this much, surgery costs this much, transplants cost this much. How can we pay for more than just the surgery? How can we actually pay for that little episode of care from, okay, we're going to do the surgery. How long does that take? Let's say like 30 days before, 30 days after. This is how much you get paid to attain these health outcomes for all the professionals and all the drugs and all the everything you need to include. Here's 200K, let's say. Okay, do what you will within that, and then it incentivizes innovation. It incentivizes improving outcomes. You tie the reimbursement to outcomes, of course giving a little bit of latitude for the appropriate amount of risk. But that value-based payment system, we're working towards it, and that's going to actually incentivize prioritizing value over cost. So those three things, having the data follow the patient, having the care follow the patient, and having the money follow the patient instead of an activity-based model that we have, that will actually provide value for our health systems. And that's where we're headed. Some provinces faster than others. Definitely from the patient advocacy view, nobody's going fast enough, but that we're here to push them and to hold them accountable. But I really do believe that it's going to be good for patients and families first, but also good for all stakeholders if we manage to do this, because then we'll get the healthcare system that we deserve, by really prioritizing health above volume of services, for example.
Great, and that's actually the second time we've heard that from someone who said, Canadians were sometimes a little too gentle. We don't forcefully ask for things, but we should really ask for things because we deserve it, right? So, but I'm going to ask a question that might get us in trouble here, but we'll see where this goes. We'll take it on, right? Let's see this. You're kind of the guest to do it with. So you had mentioned it's a great way, actually, the way you framed it, right? Data is incredibly important here. Right, you mentioned that in order to see the entire elephant, you have to see the entire elephant, not just like someone sees the trunk, someone sees the big leg, someone sees the body, and then you think it's different things, right? Now, a lot of folks would probably, maybe incorrectly, assume that, like we're a central single payer system that doesn't, like, don't we see all this already? Like, why is this even a problem, right? So clearly it is a problem. And in recent times, well, not recent, maybe the last decade or so, maybe a little bit more so than that, especially now with the push of AI, right? There's this concern around data privacy, right? Especially data privacy is a big concern, right? So now it's like, now me as a patient, going to give like some group this all-encompassing power over all my data, that they see everything, and depends on what side you're on, right? The government has all this data. That's like, now they know everything about me. I don't want that, right? So yeah, how do you think about those growing concerns in this world? Because this only works, as you suggested, if there's no data that's combined or integrated, then this system cannot exist.
Yeah. So thanks for that question, because actually I've been involved in many pushes with other patient advocacy groups in the Pan-Canadian Health Data Strategy and in the Quebec Health Data Law. And one of the main things that we were advocating for is stop assuming that patients don't want to share their data and talk to them. And when we spoke to them, they said, explain to me how you will use my data. Explain to me how you will secure my data, and I will be happy to share it. And if it's going to help me and or others, I'll be happy to do it. And one of the things that the Quebec Health Data Law included, which I think is really key to making sure that patients are reassured, is that there's a now I'm thinking in French, but there's a logging of access. So there's actually everybody who has consulted your file, you have access to seeing, my pharmacist, my doctor, my family doctor, my nurse. You have their names and when they consulted which part of your file, of your health record. That exists already now. And so it gives accountability. There's very serious fines for, breaking that. You can report someone. Let's say my neighbor is a pharmacist, but she's not my pharmacist and she's consulting my record. I can actually, tell on her and make her get in trouble. And there's huge fines, there's big consequences. So I think we just need to not paternalize patients and assume that, they're going to be so scared to share their data, but actually, how much we share our data with social media and all these things. I think we need to just tell them that it'll help us to treat them better, because today we're driving the airplane blind. We have no data and we're making potentially really poor decisions based on assumptions and not based on data. So I think it's a step up to actually collect that data, allow it to follow the patient. I mean, I was shocked to learn that pharmacists will give you a prescription without knowing what your diagnosis is, because they don't have access to your diagnosis. So then they have to play a game of charades to guess, are you taking Revlimid for arthritis or for multiple myeloma? This is crazy. Like, they should know. I want them to know. I want my pharmacist to understand what my diagnosis is, so that they can make better decisions and advise me on potential, interactions with other drugs. And so today we're flying the airplane blind. I want all of the pilots to have all of the information that they need. So they need proper dashboards. They need to see my whole health record, if that's what they need to make a better decision. But we need to collect it, and we need to collect it in a way that's good quality data that gives us confidence to make better decisions, not just for governments and HTA and reimbursement decisions, but also for my clinical care. I want everybody who deals with me to have all the information that they need, and I want them to share it with me so that me and my family can also make the best decisions for us with the right information. That's not based on population level information, but it's based on me living in East End Montreal, where I'm working from home most of the time, and I have certain hobbies that I want to maintain. And will I be able to continue doing that? Will I be able to continue working? Like, I need data to make those decisions. And today we're just assuming based on literature, based on very well-intentioned healthcare professionals. But I think that we need to start really empowering patients and families to make decisions as well. And the most equitable way to do that is to just ask everyone, collect it in a standardized way, be able to analyze it on like a unified kind of centralized platform that allows people to make better decisions, and not having disparate fragmented data silos everywhere. And that's where we're starting. So we need to actually find a way to use tools to go and extrapolate that data so that it makes sense and it helps us to make better value-based decisions.
Great. Actually, because you talked about doctors. So actually, doctors, I'm not saying that they're the only component, but there seem to be a core component of this change if change is to happen. Let's say like one day Costas is like the Prime Minister of Canada, and he's like, you know what, Eva, this is a great idea, Eva, and I'm gonna fund it. Right, we're gonna fund it as a nation. Let's all in. Here's like, I don't know, whatever it is, $10 billion, $1 billion, whatever it is. Right, here's the money, and now go off. I assume day one it's not like, okay, that's it. We got it. Like, the funding's here. We're good to go. I assume, I don't know to your experiences in these smaller pilot projects that you've done.
Yeah.
If there's challenges from like if you experience challenges from like an infrastructure perspective, from like almost like personnel perspective, like, hey, I've been doing this for like 20 years. Like, what are you talking about?
Yeah.
Right.
Absolutely. So there's a really important element that's not talked about enough in value-based healthcare transformation, and that's change management. So you really can't assume that everyone's just going to get on board. You have to actually, that's why the capacity building is important. We need to have internal local champions. At the Jewish General Hospital, Dr. Baptist, who you know well and who's probably been on your podcast many times, he was an internal champion. He really understood that value-based healthcare was the way to go. And so he encouraged some of his peers. And did all the doctors get on board right away? No, they did not. We had to actually, show them through data. The good thing is that clinicians are really convinced through data. And so you need some early adopters. When the early adopters do it, they show that it works, they have the data to show it, they can convince their peers. And so, like, if tomorrow we had millions of dollars to do this, could we do it like in 1 year? No, we couldn't. That's why our project was 2 years. And the first year was really, setting the foundations, talking to people. We didn't have to convince them too hard, but we had to take it easy and respect, what would convince them. And so at first we had one doctor, then we had two doctors, then we had three doctors getting on board. And then standardizing processes would be, an important first step, so that everyone can actually, feel confident that they're all doing it this way. This is how you do it, giving them a little bit of leeway and how to apply it. Like we used Qualtrics, but we can use any platform. We have to make it like platform agnostic, so that everyone can get on board, because we know that the health system, they all did their own thing, IT wise. And so we really need to enable everyone to get on board, understand the why, and then figure out how to apply the how in as much of a standardized way as possible. So that you're right that we can't force anything down doctors' throats. It has to be their idea. And we can help them make it their idea by showing them the data, by giving them the tools to demonstrate it themselves, to prove it themselves that it actually works. It's good for their patients. It's good for them, that they still retain full control, and that they actually will work better with their peers. The other, traditionally obstacle is getting people to work as real teams. I mean, this is a tale as old as time, right? But like, I think that having the data really encourages that team work. And then tying the financing piece is interesting, because you have to tie the financing to more than just one healthcare professional. You have to actually tie the financing to like the obligation to work as a team, as an integrated team, because otherwise people are going to continue working in silos, and that's anti-value-based healthcare. But that's exactly what we have today. We have data silos, we have working kind of functional silos, and then we have financing silos. So the way to get value is by integrating all those three with the ultimate objective that should tie everyone together, that is improving health outcomes for patients.
No, I think that's well said. I think that is really the big challenge, because everyone, I mean, it's easy to understand data silos, but those other two, people forget that those are also siloed. Those don't actually meet most of the time,
and they're interdependent.
Absolutely. The people who should see it, though, are the health system administrators. So the ministries of health and the bureaucrats that have been managing the financial resources to make it work for a very long time. Doctors may be persuaded by data. Are these administrators equally persuaded by data, or is there something else that we need? So do we need patients to be going to them and saying, listen, we've had enough. What you're doing today is not enough for us?
Absolutely. And I think that that's why patient advocates in Canada have been leading the value-based healthcare transformation, because we're demanding it on behalf of the patients that we represent. And when it comes to politics, I don't think politics are good or bad. I think it's like the Force, and I try to be a Jedi. You don't always see are the dark Sith lords, but actually, if we actually influence politicians by telling them, look, this is what your citizens want and need, and this will make you look good. So, you get to do good and look good, and ultimately everyone wins. Let's go in that direction, because, and that's why we have to tie in those economic arguments. That's why we need to tie in, like, this is what people need and this is why, because the metrics that they're used to using are obsolete. I don't think that they serve our needs anymore. That's what we had because it was the best that we had. Fine. But we're in 2024 now. Let's get with the times. Our IT systems are also getting better, and hopefully they will continue to get better. So we can do things now that we couldn't do before, but we really need to kind of rattle them a little, to make the decisions that are best for the population. And the only reason that they will do that is if they're incentivized by real patient stories, real communities getting together and saying, hey, it's not enough to give us the cheapest thing, or it's not enough. Like, we don't want austerity measures. We're all traumatized all across the country on austerity measures in the healthcare. So how can we actually do better, not have to send our cancer patients to the United States, like in British Columbia, for example, or at one point we had to do that in Quebec too. How do we actually deliver the best to our population within our capacity to pay? And then showing the population that what we're investing in actually makes them better, And I think what we're missing too is like more investment in primary care and early detection and screening, demonstrating that that's really much better for patients and families, but it's also better for the system because we know it theoretically, but we've never done that. I mean, we saw during the pandemic how underfunded public health was. And so I think that, flipping that model right now, the pyramid, of our investment is like we spent the most in hospital care, then a little bit in chronic care, and so little in primary care, right? But if what we need, what the patient population needs or the community needs is more in prevention than medium level in chronic care and maintenance, and then only a little bit in acute care, because ideally less people would have to get there because we did such a good job preventing things in advance. And so that's also a mind shift. Like, what do we spend money on? But politically, it's more sexy to build big hospitals and buy MRI machines than to spend a lot of money in prevention that takes years and years to show results. But we'll never know if we don't measure. And so you can only improve what you measure. That's where we got to start.
So what I hear is less ribbon cutting and more healthy people.
Exactly. And you know what? Really show me the data. Like, show me that people are doing better. Like, hold me accountable for a healthier population. Let's lower mortality. Let's improve the lives of people that have chronic disease. Let's take deadly cancers, make them chronic, and then chronic and make them curable, but show me the data, and let's judge our politicians based on how healthy they make their population and not just the ribbon cutting ceremonies.
Well, Eva, this Prime Minister approves that message. I would be very happy to see that future.
Yeah.
I was going to suggest that you should that should be how you enter in and do any of these presentations. You dress up, basically, you do the Tom Cruise thing. Go ahead, show me the data, right?
Exactly.
I just pictured you doing that. So I know we're way over time already. Thank you very much for being so generous with your time and helping us better understand what value-based care means and all the great work that you're doing, Eva, and of course your organization that is doing as well. So I'm just going to make sure that people know where to find you, so that you can go to coalitioncancer.com for more information about your organization that you're the executive director of, Eva, and also on Twitter or /X, you can follow Coalition Cancer. So that's at Coalition Cancer, and that is anywhere else you want people to...
Yeah, I would say LinkedIn. They can follow me and the coalition on LinkedIn. Twitter is less used these days, but definitely Twitter, LinkedIn. We're on Facebook as well with the Cancer Coalition, Coalition Priorité Cancer au Québec. But our LinkedIn is a really good place to follow what we're doing and what I'm doing in the value-based healthcare as well.
Well, great.
Thank you very much. We look forward to that report coming out October 15th, just reminding everyone on colorectal cancer. So thanks for joining.
Very, very exciting. Thank you very much, everyone, for tuning in today and listening to our great conversation with Eva. Very, very appreciative of that. If you like this podcast, please like and subscribe to the podcast. And if you have any questions, feel free to comment below, or just any feedback as well, comment below. So thank you very much and have a great day, everyone.